Good morning, good afternoon, good evening. Welcome everyone to this first WFH webinar. We are very pleased to host this webinar in collaboration with the ISTH. My name is Fiona Robinson and I am the Manager of Educational Materials here at the World Federation of Hemophilia. Before we get started, I would like to take a moment to review a few technical matters and let you know how you can participate in today's session. First of all, if you experience any technical problems during the course of this webinar, you can click on the Request Support button in the lower left of the player. We have a technical expert standing by to help out with whatever problems you may have. We would like today's webinar to be interactive, and we encourage you to submit questions to our presenters by typing them into the Questions tab on the left side of your screen. Please feel free to submit your questions at any time. When asking your questions, you can specify which speaker you would like to address it. We'll take as many questions as time permits at the end of the webinar, and some of the speakers may also follow up on some of those questions by email after the end of the event. There's also a neat feature that I'd like to point out if you would like to take notes during the presentation. If you click on the Notes tab on the right side of your screen, there's a white text box there, and you can take notes throughout the webinar, and these will be emailed to you automatically at the end of the presentation. If you're interested in a PDF copy of today's webinar slides, you can click on the Resources tab on the left side of the player and select the file there to initiate the download of that PDF. And finally, we'll be running a few polling questions to start the session and again at the end. So we'll actually start with these right now. You should see a polling window in the middle of your screen right about now. And here you'll find 3 questions. They have multiple choice answers, and you can simply click the option you wish to vote for. If you would take a moment now to answer those questions, I'll just read through them quickly. The first question, what is the optimal time to begin prophylaxis for a person with severe hemophilia? A, by 1 year of age. B, between the ages of 1 and 3 years. C, after the first but before the second clinically evident large joint bleed. The second question, can prophylaxis be an effective strategy to treat hemophilia in resource-limited countries? A, no, limited resources should be reserved for on-demand urgent treatment. B, yes, low-dose prophylaxis can achieve beneficial outcomes with limited resources. And our third question, which of the following may help developing countries to overcome the obstacles to increase early laboratory diagnosis capabilities? A, additional personnel training. B, participation in an external quality assessment scheme. C, in-house preparation of reagents. D, collaboration with other hemorrhagic disorder diagnostic initiatives, or E, all of the above. So please take a moment to answer these questions now. We will come back to them at the end of the webinar. And while you do that, I would like to ask Dr. Marijke van den Berg in Amsterdam, the Vice President Medical of the WFH and our moderator today, to introduce our speakers and today's webinar. Marijke?
Good morning and good afternoon for wherever you are in the world. It's my great pleasure to introduce the speakers for today. We are very happy to have 3 speakers. The first speaker will be Professor Rolf Ljung from Malmö, Sweden. He has a long record in treating children with hemophilia and is very knowledgeable in this field, and he will give us the first speech. Then the next speech will be by Professor Johnny Mahlangu from the Witwatersrand Hospital in Johannesburg, South Africa. He's coming from a more resource-limited country, but he has succeeded over the years to start prophylaxis, so it's very important to get his thoughts about this. And the third speaker will be Professor Sukesh Nair of the Christian Medical College in Vellore, India. He has been working with the WFH and has been giving workshops and training on laboratory diagnosis in the developed world. And he will give his thoughts about what is needed to extend the diagnosis for patients. So with this, I would like to give the microphone to my colleague, Dr. Ljung, who's by instance sitting next to me. So, Rolf, here you go.
Thank you very much, and hello to all of you around the world. Yes, as Marijke said, we have a long tradition of prophylactic treatment in Sweden and in Malmö, where I have worked for several decades. And I would like to give you a few aspects of the prophylactic treatment, the way we do it today. And on the first slide, you can see the agenda. I will talk mainly on the prophylaxis, the Swedish model, but also how you can personalize this model. First, let's agree that there are actually mainly two key obstacles for global availability of prophylactic treatment, and that is actually the cost of treatment and the need for venous administration. Just imagine if we had a cheap pill that you can administer orally every day, we wouldn't need this webinar. In the next slide, I would like to show you how we do primary prophylaxis in Sweden today. And remember, it took us several decades to get to this point. We start regular prophylactic treatment at the age of 1, whether the child has had a serious bleed or not. And we usually start with 25 units per kilo per dose, and that, a child of 1 year usually weighs around 10 kilos. So it's very useful to have the 250 unit vial. I don't see any reason to wait for the first joint bleed. Why should you? It will come sooner or later. And actually the first bleed could be an intracranial bleed after trauma. So one has to take that into account. However, during the first 20 exposure days, we would like to avoid immunological danger signal and intensive treatment periods. For example, a surgical procedure, if it can be postponed. We start once per week, but that is for practical reasons, so the child and the parents get used to the venipunctures. But, that is an important but. It is our aim to reach 3 times per week or every second day in Hemophilia A and every third day in Hemophilia B. Usually after a couple of months, you know if it is possible to use a peripheral vein or we need a central venous access device to reach this frequency of injection. And in our hands, about 1/3 of the kids needs, but actually 2/3 don't need. We educate the parents, and usually the child can be on home treatment after a couple of weeks or a month, whether in a peripheral vein or in a central venous access device. Then at the age of 10 to 12, usually when the child attends a summer or winter camp, they start to self-infuse. And at the age of 10 to 15, many kids are very physically active and then we try to introduce actually daily prophylaxis, which will save quite a lot of concentrate, and every day is the same for the child. Then continuous education of parents and children, and we allow most daily activities, and we really want to avoid social stigmatization. This sounds like a one-size-fits-all model, but as you can see on the next slide, all prophylactic models needs to be individualized or personalized. And in what way should they be personalized? First of all, should you treat Hemophilia B the same way as you treat Hemophilia A? And our answer is yes, you should. We have very clear data from the PEDNET registry that at least in children there doesn't seem to be any difference at the time for the first bleed, the time between the first and second bleed, and several other parameters between A and B. Then I think you have to ask yourself, what is actually the aim of prophylaxis? Because if you start already in a child who has pristine joints, there is usually a need for less units per kilo compared if you start prophylaxis in an older hemophilia person with already established target joints. And in the last case, perhaps your goal should be to avoid a progressing crippling arthropathy, but in the first case, perhaps the goal could be set that you should actually avoid that the child ever gets arthropathy. You have to take into account the bleeding phenotype. We have always been taught that 15% of severe hemophilia bleed less than the others, but actually you have no good way to know who these are, and I don't see any reason to wait and see the bleeding phenotype. You have to take into account the physical activity of this child. We also know today that you have a different susceptibility to arthropathy. Some patients may never have reported a joint bleed, still they have arthropathy ongoing, suggesting they have micro or subclinical bleeds, while other patients may have several joint bleeds without any arthropathy. You also know you have different pharmacokinetics. The inter-individual differences may be quite large, and also children have another pharmacokinetics than adults. Venous access, compliance, and finally the resources in the healthcare system actually sets the limits. So this sounds very good, but then you may think that, well, we can never afford anything like the Swedish model. But then I would like to say that, and I know that the next speaker will talk more about it, that a low-dose prophylaxis, if you start with 10 to 50 units per kilo per dose, will be much better if you repeat that dose regular than, for example, giving 50 units once weekly. It's much more efficient to divide these 50 units in 3 doses, for example, during a week. And here, perhaps the extended half-life products may be a new tool we have to reach such a goal. In my final slide, I would just like to draw your attention that if you look at the x-axis, you have the dose in units per kilo. And if you start by just giving 10 units per kilo on a regular basis, which was actually more or less what we did in Sweden back in the 60s and early 70s, you will really gain a lot of improvement shown by the reduction of bleeds on the y-axis. Then if you double or even triple the doses up to 30, it will of course be better, but you will not get 2 or 3 times the outcome, but you will refine it, and you can reach other goals like living almost a normal life. So my message is that we think you should start from an early age, as soon as possible after the age of 1, where venous access gets a little easier, and give frequent dosing. And then your resources in the healthcare system will decide, how large doses you can administer on this regular, frequent prophylaxis. But the most important thing is to start early and give it more than once a week, and that will give your child a very good start of life. And that was my message. Thank you very much.
Okay. The next speaker will be Professor Johnny Mahlangu. I will give the floor to him. Please, Johnny, go ahead.
Thank you very much, Marijke, and I would like to thank the WFH and ISTH for inviting me to participate in this webinar, but also perhaps most importantly to do a webinar on the developing world in which I live and practice. I have no conflict of interest to disclose in the context of this presentation. And the agenda for the next 15 minutes is a fairly simple one. I would like to review together with you around the world the benefits and the barriers to prophylaxis. And I would also want to explore some of the prophylactic options that are available for the developing world. Just as a reminder, there are many benefits of prophylaxis shown in many studies, and this particular slide does not claim to be exhaustive. It's just to remind you that the primary prophylaxis has the potential to reduce the number of bleeding episodes, certainly in some of the studies in excess of 80%, and consequently improve the joint function associated with the reduction in the number of bleeds. Prophylaxis also is associated with the reduction in the deterioration of clinical and radiological features that we see as a result of bleeding. Because of this reduction, we see fewer days lost for the people with hemophilia who are attending schools or work. In the famous Mahlangu-Johnson study, it was shown clearly that there is a significant reduction in joint damage, up to a 6-fold reduction as shown by the MRI, and also a 7-fold reduction in the number of bleeding episodes per patient per year, which is obviously one of the most important benefits of prophylaxis. Last but not least, we would want to see the people with hemophilia attaining lives that are close to normal. And one of the benefits of prophylaxis is to increase the ability of the people with hemophilia physical activity, but also to preserve their bone mass density in a way that allows them to be able to participate in a lot of physical activities. So if one examines some of the barriers of prophylaxis, and these are barriers globally that one sees in developing and developed world, for convenience, I've divided them into 3 groups: the patient-related factors, the physician factors, and the clotting factor concentrate contribution. And if one looks specifically at the patient-related factors and the physician-related factors, they apply across the board in developing and developed countries. As you have heard from the previous speaker, venous access is an issue in the context of patients. There's no doubt in my mind that there is non-adherence across the board, etc., etc. And for the purposes of this presentation, I would want us not to focus on those patient and physician factors, but to focus on the clotting factor-related factors, which in my mind are the differentiator between the developing and the developed world. And in this regard, access to clotting concentrate is one of the biggest barriers, and in this regard, in fact, the WFH humanitarian aid plays a very important role. Perhaps even more important and closer to home is the ability of the host country, the host organization, and even the patients to be able to acquire and pay for the clotting factors. So given that the clotting factors are clearly some of the most important barrier to prophylaxis, I just want to illustrate some of the obvious things that perhaps sometimes we take for granted. When we treat people with hemophilia, we do have in our mind therapeutic goals. They may well not be written somewhere in our charts, but they are always in our mind. Starting from the bottom of this schema, we often are reactive and we treat bleeding episodes. In doing so, we hope that we are going to prevent hemopathy, arthropathy, which is secondary to bleeding episode. we then tend to want to maintain the bleeding score once we do not have deterioration of joint structure. We want to enable our patients to be able to care for themselves. In other words, to undertake activities of daily living with ease. We also want them to start to adventure and actually strengthen their bodies to prevent bleeds. And ultimately, the ultimate therapeutic goal in all of our mind is to be able to allow them to live a normal life. In other words, a life that is not different from a person without hemophilia. There are various strategies that one employs in achieving these goals. If one wants to prevent bleeding, you could do it the reactive way, which is you give episodic treatment. And in fact, the sequence of progression as one moves from treating bleeds to enabling normal life culminates ultimately in primary prophylaxis, which is probably the most effective strategy in allowing the people with hemophilia to be able to live a normal life. What is clear from this illustration is that as one gains the benefits of prophylaxis, inevitably one is increasing the cost of caring for people with hemophilia. So the message clearly is that if you have an effective therapeutic strategy, you should expect to pay more for a good outcome, which is essentially enabling normal life. Now, how is cost managed in the context of hemophilia? The cost drivers in hemophilia and prophylaxis in particular are twofold. One is the cost of achieving a particular dose to prevent a bleed, and also the cost of dosing in a particular frequency that is effective enough to be able to render prophylaxis effective. And I want to tackle both of these factors that are cost drivers in hemophilia and prophylaxis. In the classical approach that you've heard from Professor Ljung, the sort of paradigm approach in the developed world where probably they have access to a lot of resources is that they tend to use quite largish to large doses. You heard that 25 units per kg per dose is what is used in Malmo, and in fact in some parts of the world they go as high as 50 and beyond. You will then need to give the dose in the frequency of 2 to 3 times a week if it is factor 8, or 1 to twice a week if it is factor 9. And you're looking at a total dose, total units per kilogram per year of between 3,500 and 8,000 units in that setting. The implication, of course, is that you should have the resources to support that. The per capita sort of expectation is somewhere above 5, and it's certainly in the latest WFH global survey, it would appear that some of the really, really well-to-do countries go as high as 16 and 17 IU per capita, and at a very high cost of between $200,000 and $400,000 per patient per year. Shift the gear, and you want to see whether prophylaxis is possible in the developing countries. One has to take a different paradigm. And I'm giving here a hypothetical country. It could be South Africa, it could be anywhere in the world, with a population of 50 million people, in which we expect 5,000 people with hemophilia, severe hemophilia A, if one takes the rate of 100 per million. Severe hemophilia A patients will be in the region of about 3,000. That's basically sort of the figures that one uses all the time. And I just want to switch over to the latest data from the WFH annual survey. Fascinating enough, the median global per capita factor usage in the countries that were reporting consistently, in this case, it was the 54 countries that had reports in 2014 and 15, was on average 1 IU per capita. Now, if one uses that 1 IU per capita as a benchmark, in this hypothetical country, you will see that you will have in your hands 50 units for the country, And if you say that you have not identified all of the severe people with hemophilia, say you've identified 90%, so we're talking about 45 units that are at your disposal. And this would amount to 15,000 units per person with hemophilia per year, which translates to about 300 units per person with hemophilia per week. If you take an upper end of a child's weight of 30 kilograms, you'll see that you could literally give 10 units per kg per week in a child that is 30 kilograms in a country that can achieve 1 IU per capita. That, to me, is an illustration that it is possible in a developing country to be able to implement prophylaxis. And the question then you ask perhaps is twofold. One is, do we know that 10 units per kg per week works at all? And the answer to that, in fact, is actually in the history. I apologize. These are old studies that were reported in the pre-clotting factor era in some instances, but they illustrate the point that in all of these studies, you can see that the dose given was anything from 3 units per kilogram body weight to as high as 30 units per kilogram body weight, and the success rates were anything from 67% to 100%. So to answer the question, it is possible to achieve success rate with some low doses of factor, even though the propensity in 2016, 2017 is for us to give much higher doses than what is reflected in this slide. And the next question, of course, is if it works in the context of treating bleeds, does it work in the context of prophylaxis? In fact, in this context, we don't have a lot of experience. We do have a single study from China where they use low dose of 10 units per kg twice a week in the context of secondary prophylaxis. As you can see in this diagram taken from their published paper in 2011, that there is a huge difference between the observation and the prophylactic group in both the severe hemophilia and the moderate hemophilia setting. So it is just a good beginning and proof of concept to most of us that low-dose prophylaxis, certainly in the context of 10 units per kg twice a week, has some benefits to the people with hemophilia. Do we have some more experience? Certainly, some of this experience has been communicated in international meetings and not been published. We talk here about the Moroccan experience of low-dose prophylaxis in primary prophylaxis, and it would seem that, in fact, it does work in that setting. And perhaps what is very encouraging is the study that was done by Alok Srivastava from Vellore, a multi-center international study, which showed that low dose was effective in preventing bleeds, but not only that. There was actually not a lot one gained from increasing the dose. So the current evolving paradigm is that we should explore the possibility of prophylaxis in the developing world, where clearly low dose has not been used that often, and certainly there is now studies to suggest that there will be benefit to our patients. If I switch over to the other cost driver, which is the dosing frequency, there aren't a lot of data on the dosing frequency, and in this regard, I would like to indulge into the very latest extended half-life products, in particular the very impressive recombinant factor 9 extended half-life product. Shown here are the 3 pivotal studies that have been done on the extended half-life factor 9 products, and you can see that in the dosing frequency has been anything from 7 days, every 7 days to every 14 days. What is perhaps very impressive is that the annualized bleeding rate has been on average between 1 and 3. You can see the range is very wide from 0 to 6, but that is actually very encouraging. In other words, if we're to solve the second cost driver of prophylaxis as a barrier to prophylaxis, exploring the possibility of dosing frequency manipulation will certainly help us in that regard. And in summary, I would like to answer the question that was posed right at the beginning. Is prophylaxis in the developing world possible? Yes, I would answer prophylaxis in the developing world is not just a dream. It is a reality that we can attain and implement. In my view, it is achievable through a number of approaches. I've alluded to two of those approaches here, reducing the dose and reducing the dosing frequency, especially when one is using extended half-life products. And also, perhaps to finally say that these approaches will then allow us to reduce the barriers to prophylaxis which currently are existing in the developing world, and to allow our patients in the developing world to benefit from prophylaxis. Thank you for your attention.
Thank you. Thank you very much. It's very important, this support for prophylaxis from your part of the world, and we hope it will be extended to many countries more. So the next presentation will be from a different page. I would like to give the floor to Professor Sukesh Nair from Vellore, who will give us a talk about laboratory diagnosis of bleeding disorders challenging in the developing world. Please go ahead, Sukesh.
Thank you, Marijke. Hello to everybody who's attending the webinar from different parts of the world. Now that Professor Johnny Mahlangu has said that prophylaxis in the developing world is not just a dream, but a reality, we now need to look at factors that could come in its way, most important being laboratory diagnosis. Not only that a patient with increased bleeding tendency is correctly diagnosed as hemophilia A or B, but more importantly, the ability to correctly identify inhibitors, which becomes essential as and when prophylaxis program is implemented. But challenges do exist in the developing world, and I would like to take this opportunity to demonstrate this over a few slides, for which I will first briefly outline the minimal requirements for the laboratory diagnosis of a patient with increased bleeding tendency, especially in the context of hemophilia. Then I would go on to what are the challenges in the implementation of some of these basic requirements, and finally illustrate with examples some of the workable solutions to overcome these challenges. Laboratory diagnosis of a person presenting with increased bleeding tendency will be basically an algorithmic approach which follows an abnormal screening test, which in the case of hemophilia would be an abnormal APTT. This would be followed by a mixing study to determine if it was factor deficiency or an inhibitor that was causing the abnormal screening test. And finally, it will be followed by a specific assay to confirm either. To determine the efficacy of this laboratory to provide an accurate diagnosis, this can be done by making the laboratory participate in a very good proficiency testing program, the one like WFH provides, the World Federation of Hemophilia International External Quality Assessment Scheme Program, or the WFH IQUS program. The WFH IQUS program is actually sourced from an accredited PT provider, which is the UK IQUS, based out of Sheffield, whose program director is Dr. Steve Kitchens. Participants are mostly from hemophilia treatment centers from various countries all over the world, but located in their major cities. Though UK IQUS provides the service at a very subsidized cost to WFH, WFH still pays for 94 of these laboratories out of 145 participants to participate in this program. These 94 laboratories are mainly from the developing world, which actually may not have access to any other good IQUS programs or proficiency testing programs. From these laboratories, 39 are from Asia, 17 from Africa, 18 from East Europe, 20 from Central and South America. There are actually 6 challenges that are done over 3 rounds in a calendar year. And looking at the data from the WFH IQUS, 22 of the 94 laboratories do not consistently, or in some cases, never return results of the screening test, which includes APTT. And always the reasons cited are, there are no reagents available. What was available earlier have been exhausted, and there are no new purchases of reagents as there are no funds provided for these reagents. Of course, one lab did mention that they had an issue with skilled personnel. Non-returns become worse when it comes to factor VIII assay, where 91 of the 94 laboratories have actually registered to express interest in doing factor VIII assay, of which 38 of them are unable to return results for the same reasons, which is unavailability of reagents for factor VIII assay. But what is more alarming is that out of the 53 who actually do return results, almost half of them have issues with reliability of factor VIII assay method, since they are nowhere close to the accurate value. Fortunately, WFH provides supports to these participant laboratories to help troubleshoot their poor performance. WFH funds a visit to the laboratory by an expert who volunteers for WFH to do the root cause analysis and implement the corrective action. At the same time, there will be support provided by UK NICPO staff in providing extra material, which could include a WHO or a SSC standard. The same can be done through also email connection with an expert. This slide shows one such example where a laboratory that was a regular participant in factor assay was having issues with factor assay results. As you can see on the left side, the laboratory returned a result of 44 international units of deciliter on a EQA sample or a proficiency testing sample, which was numbered W0914, where actually the consensus or the expected value was supposed to be 29.3 international units per deciliter. This, of course, had a positive bias and was graded with an uppercase D, which is an outlier. If you actually see the 9th row of this report, it reflects the laboratory's grade in the past two surveys too, which two are almost similar with a significant positive bias, one being worse at E, capital E. The root cause analysis of their method revealed that they do a one-stage APTT-based assay using commercial reagents from an international reputed IVD manufacturer, which are supplied through an agent, with all consumables were within expiry period. The raw data was requested so that we could plot the values manually on a logarithmic graph paper. And for that, we also used the raw data from a laboratory that did very well on the same sample. As you can see on the right-hand side, we selected a lab which actually got the same value as the target value. On the left-hand side is the graph of the lab which was not performing well. Though their standard graph was a straight line connecting all the dilution, which too was actually seen with the test plasma. And in addition, there was parallelism, making it look like a good assay graph. With their internal quality control falling within limits, the laboratory assumed that all was fine. But now when you compare it with the lab which was doing well, which is on the right-hand side, the problem became obvious. The laboratory having recurrent assay problems was using deteriorated reagents, especially both the reference plasma as well as the factor deficient plasma or the substrate plasma. The reference plasma, which is the calibrated plasma, has the dilution which represents 100%, is having a far more prolonged timing. And the substrate plasma, which is the factor deficient plasma, where the difference among the dilutions were very high, of a value of 13 to 14 seconds between each dilution as compared to 6 seconds on the graph on the right-hand side. So here is a laboratory in a developing country which is able to do factor assay but fails in its accuracy because the agent who supplies reagents representing the good IVD manufacturer has compromised on the reagent stability. Now the solution was to get fresh reagents, and knowing the scenario, we recommended that they prepare both reference plasma and factor deficient plasma fresh in their laboratory from volunteering donors. The substrate plasma or the factor deficient plasma may be harvested from a consenting patient with severe hemophilia A to make sure that the harvested factor deficient plasma is well suited. It should have actually no factor at all, definitely no factor inhibitor, in addition to which it should contain normal levels of von Willebrand's factor and all other clotting factors. Moreover, it should be negative for viral markers. The reference plasma can easily be made from pooled normal plasma, as in the case of most of the calibrated plasmas that are commercially available. This is by harvesting plasma from consenting normal individuals. Ideally, the concentration of factor VIII and factor IX in the resulting pooled plasma should be close to 100 international units per deciliter, and ideally should be calibrated in international units either with another calibrated plasma or a standard reference plasma. However, we also are aware that international units of 100 international units per deciliter can usually be achieved by pulling plasma from 20 normal individuals. But this actually requires a lot of effort, which is worth if aliquots of the resulting pool can actually be stored appropriately. We did demonstrate to the lab that, like larger pools, even smaller pools could also contain close to 100 international units per deciliter of factor 8 and factor 9, though not recommended, but it at least requires less effort, which at least is far better than using plasma from a single random normal individual, which cannot guarantee the ideal level of 100 international units per deciliter. So, and instead of evaluating if a factor deficient plasma is ideal, a difference in timings between the dilutions of reference plasma being between 5 to 9 seconds is a reflection that a good factor deficient plasma is being harvested, and the dilution, which represents 100%, which is 1 in 10, which gives a time between 52 to 65 seconds, will demonstrate that not only is the in-house harvested deficient plasma good, but the in-house pool of normal plasma may have factored close to 100 international units per deciliter. These 2 points can be very easy and effortless parameter, helping them fulfill not only the reagent to qualify for the test, but also the quality requirements of factor assay, either when there is no supply of assays for factor no supply of reagents for factor assay, or if the quality of reagents have deteriorated. A good proficiency testing program, a request program, also helps reveal not only method deficiency, but when they send out a diagnostic challenge, it could actually reveal deficiencies in their practice in the diagnostic approach and algorithm. In one such exercises that was sent by the WFH ISTH in 2013, it involved sending to the participant plasma from a 10-year-old patient with severe hemophilia A who had been multiply transfused. With the clinical details provided, most of the laboratories got the diagnosis correct. But if you notice the table, only 15 out of the 35 laboratories had mixing studies in its algorithm. And what was more alarming, that only 3 of them did extended incubation to look for an inhibitor, revealing that their diagnostic algorithm, followed by many of the participants, which are actually hemophilia treatment centers, has a potential to miss factor VIII inhibitor, and identification of which is important before prophylaxis is initiated to look or for development of inhibitors in patients on prophylaxis. These differences in practice diagnostic approaches can be overcome by harmonization that can be achieved by various available training programs provided by the International Society of Thrombosis and Hemostasis and the World Federation of Hemophilia, like the Joint Training the Trainers workshop, the ISTH and WFH fellowship to expert centers, especially the one that WFH sends to International Hemophilia Training Centers. Many of the WFH twinning programs between a developing center and an expert center can be beneficial to the developing center, which some of the trainees actually send back to their centers with startup reagents and sometimes on occasion with even coagulometers. After the training, it is easy to identify these centers, and WFH can enroll them in the IEQUAS program to develop their confidence that what they have established after training is reliable. The data from IEQUAS has revealed the major limitations, which are inadequacies in trained personnel, inadequacies in procedure, especially in relation to mixing studies with a high risk of missing inhibitors. In addition to this, it's the nature of the coagulation laboratory that also adds to the inadequacies because of lower sample numbers, which result from low referrals due to lack of awareness of bleeding disorders among medical personnel, which is compounded by short shelf life of reagents, high cost of reagents and consumables, make it very difficult to sustain a service. And finally, coming to the biggest inadequacy is the non-availability of reagents. Not even the question of quality reagents, just non-availability of reagents. Unfortunately, these reagents are lower down in the purchase list, especially when funds are low. Maybe these tests get a lower priority. It's a paradox that not so uncommon and life-threatening hemorrhagic disorders like postpartum hemorrhage, viral hemorrhagic fever, trauma coagulopathy requires the same tests for their management, especially in determining the right product of choice for correcting the coagulopathy. Blood banks in most of the developing countries produce components, but they do not have tests to determine the quality of what they produce, like factor VIII levels and fibrinogen levels in fresh frozen plasma and cryoprecipitate that they make. And these same tests actually help in the rational use of these blood components. Maybe a strategy to develop a coagulation laboratory in transfusion services could convert these tests from low priority to high priority testing, which will ensure sustenance of a coagulation laboratory, which will be a major benefit to the bleeding disorder community. So the recommendations would be increasing awareness of laboratory management of hemorrhagic and bleeding disorders through seminars, workshops, and advocacy that management of both have similar algorithmic approach. Implementation of rational use of blood components and graded system of laboratory testing, followed by enrollment in an EQUAS program. Reliable laboratory tests need to be developed within the cost constraints by making in-house reagents. And programs of ISTH and WFH in training laboratory personnel will help achieve this goal. Finally, I would like to thank WFH volunteering for whom made me aware of working in any form of constraints, the staff of WFH IEQUAS which provided the data, and my colleagues at Vellore. Thank you very much.
Thank you very much, Professor. Thank you to all of our speakers today for these really very informative and interesting talks. In a moment, Dr. Vandenberg will moderate the Q&A session, but first we'll return to the 3 polling questions that we looked at earlier. Again, you should see these questions in the middle of your screen. Please take a moment to answer each of them again, selecting from the multiple choice answers. You can select a different answer than you did at the beginning if you've changed your mind. You can check the polling tab on the left side of the screen if you want to see the results of this poll, and we will show you both the results from before the webinar and just now. So please go through and answer these questions. You may take your time to do it. While you are answering them, I just wanted to let you know that today's webinar is being recorded, and the archived event will be available on the WFH e-learning platform for you to view and share with your colleagues by the middle of next week. If you have any questions for any or all of our speakers today, please type them into the questions tab on the left side of your screen if you have not already done so. Dr. Vandenberg, if you would like to select a few questions to pose to our speakers, I'll hand over to you now.
Okay. Thank you very much. I'm just looking at the results of the polls. Of course, they will be given to you too, but it might be good to start off with some of the answers. Let's look at the results. I have first the results. 1, what's the optimal time to prophylaxis for a person with severe hemophilia? The most is 47. They want to start after the first or before the second evidence of large joint bleed. But 30% want to start at the age of 1. I think my colleague Rolf Ljung is already quite pleased with this. I hope over the years this will be becoming larger. And it's again now in the second phase, so that was what people polled before his presentation. Now after his presentation, almost 70% is going to start at 1 year of age. And so it's very good to see this. Going to the second question, 90% is convinced that, and that's going up to 100% almost, that prophylaxis is an effective strategy, also for resource-limited country. And I'm really pleased to see this. I think we have to accept that on-demand treatment is not a strategy anymore for severe hemophilia. But that all patients should get the benefit of preventing bleeds. And then the Human 38 program of the WFH is also being intention to have available low-dose prophylaxis in developing countries for young children, to give them the benefit, and hopefully that we can sustain this program over the many years. Currently, with all the new products and gene therapy available, this should be something that we want to give for all our patients. Then, polling question 3, I think that we're also pleased to see that everything is needed to improve the care. Then I have a few times more for the questions that has been answered. The one question was about, can we give even a much lower dose, so going to 3 units per kilo? I think we have to think about the reason for prophylaxis is changing a severe patient into a moderate patient. And whether you need to have a level of above 1% all the time, we don't know. But we do want to have them covered all the time. And there are many studies now that see the time that patients are below 1% makes them of a higher risk for bleeding. So, of course, it's always a balance, but I think we need to establish this lower dosing, and I think the 10 to 15 units has proven to be very beneficial, probably not prevent all bleeding, but prevent bleeding to a large extent. We have a little bit time about other questions. I have a question about gene therapy, and that's an interesting question, whether we think gene therapy will eventually become a viable treatment in the developing world that would reduce cost compared to factor products. Of course, gene therapy, we see that we think it's for hemophilia B, is becoming really available, and the results, most recently results on hemophilia A are very promising, and it will really be, I think, I remember a paper that has been written some years ago by Mark Skinner and Katie High about landlines and cell phones, that the developing world is passing by on the landlines and going directly to the cell phones, and that also here for gene therapy, that they will get access to gene therapy probably even before that it will be accepted in the developed world, where we have access to a lot of variety of good products, and patients are not that willing already to take any risk. And of course, that's much different when you have no choice at all. I'm just see if we have any other questions now that we can address. I have a question here. If there is still a place for cryo in the treatment for hemophilia A, Rolf, do you want to answer anything about this? I think the problem is we need a lot of products, and I'm not sure what we want to do with this. Is there any of my speakers, probably Johnny, can you ask you to respond to cryoprecipitate and other plasma product? What's your idea about this?
Thank you, Marijke. I'll give you my view. My view is what you alluded to earlier on, that perhaps one should take a backseat and say, where there is no factor at all, in other words, patients are not being treated, giving patients cryo is better than not treating them at all. Where you have the potential, and in fact, you may well have access to clotting factor concentrate, giving the patient cryo probably is not ideal. And I'm not saying it's not acceptable, but it's not the best that one can do for our patients.
Thank you for that. I have a question also for Sukesh, a question about when, what will be for the criteria for centers to be eligible to participate in the IAQUAS program?
Actually, the easiest way to get into an IAQUAS program is to get in touch with the NMO, but or write an email to the IAQUAS committee program officer in WFH, which is Stephanie Pineda. I will email Dr. Shabnis the email ID of Stephanie so that they can make inquiries on how to enroll for the WFH course.
Okay, thank you for that. And probably a final question I would like to give Professor Ljung the opportunity. Will early prophylaxis not produce inhibitors earlier?
No, it will not. About 10 years ago, it was thought that if the age has an impact on the risk of inhibitor development, but it's not the age as itself. It's actually the reason why you treat it very early that is a risk factor. So if you postpone prophylaxis, you will get the same number of inhibitors, but a little later, because those patients who are genetically determined to get inhibitors, they will get it whether you start early or later.
Thank you. I think I have a few more minutes for my conclusions and conclusion, in fact, for this webinar. I think we all agree, and it's wonderful to see it in the voting, that prophylaxis is the preferred treatment for all patients or people with severe hemophilia, and that on-demand treatment is only for acute bleeds. To prevent arthropathy, prophylaxis need to be started earlier, potential even already as 1 year of age. And in the last slides, I'm not sure whether I had added a figure, but yes, here it is. This is from recent data that we published from the PetNet group, and it shows that when we look for a lifelong perspective, the only opportunity to prevent arthropathy is start very early. As soon as patients started after some year of joint bleeds, you never will have pristine joints anymore. The arthropathy will continue to happen and never will be influenced, even not with gene therapy. So there's only a gold window of opportunity. So, Fiona, do you have some last housekeeping minutes for us? And I would like to thank all the speakers for participating. Thank you very much.
Yes, thank you very much, and thank you, Dr. Vandenberg, for moderating this webinar. The only final housekeeping matters that I have are to let you know that the slides, the PDF of the slides, will be emailed to all of our registrants on close of the webinar, and to remind you that the archived version of the webinar will be available on our e-learning platform next week, and we'll send you an email to let you know when that is available as well. So thank you, everybody, from participating from all over the world. We really appreciate that. I've seen in the chat window that people have been online from all over the world. So we want to wish you all the very best from the WFH, and we look forward to hearing from you again when we have our next webinar. Thank you, and goodbye.